Bismillahirrahmanirrahim. I welcome you, ladies and gentlemen, to this session on epidemiology and prevention of tuberculosis. This is the first lecture of a series of lectures on tuberculosis. By the end of the session, we will have discussed the following related to tuberculosis: what is tuberculosis, a little bit about the history, about the burden of disease, epidemiological determinants, types of tuberculosis, pathogenesis, childhood tuberculosis, HIV and tuberculosis, prevention, and at the end, I will summarize. As regards tuberculosis is concerned, it's an infectious bacterial disease caused by Mycobacterium tuberculosis and most commonly affects the lungs. It is transmitted from person to person via droplets from the throat and lungs of people with active respiratory disease. Historically, tuberculosis has been called by different names, including consumption thesis, scrofula, Pott's disease, and the white plague. It is generally accepted that the microorganism originated from other, more primitive organisms of the same genus Mycobacterium, and researchers have theorized that humans first acquired it in Africa about 5,000 years ago. In the historical context, Hippocrates, in his book, describes the characteristics of the disease, which he says include fever, colorless urine, cough resulting in a thick sputa, and loss of thirst and appetite. He notes that most of the sufferers become delirious before they succumb to the disease. Whereas Aristotle uh, uh, disagreed with Hippocrates. Hippocrates said that it is a hereditary disease, whereas Aristotle said that it is a contagious disease. Later in the 19th century, in 1865, it was proved that tuberculosis is contagious, and Robert Koch discovered the Mycobacterium tuberculosis in 1882. Then sanatoriums were being established in US and it started off in 1884. However, in the mid 70s, most TB sanatoriums in USA closed. In 1943, streptomycin, a drug to treat TB, was discovered, and then from 43 onwards till 52, two more drugs were discovered to treat TB, which included isoniazid and pyrazinamide. As regards the epidemiology of tuberculosis is concerned, Karel Styblo, who was born in Czechoslovakia, is known as the father of modern TB epidemiology and also the father of modern TB control. He is internationally renowned for his work with tuberculosis and worked as a medical advisor with the Royal Government of Netherlands. As regards the global burden of disease is concerned, worldwide TB is one of the top 10 causes of death and the leading cause from a single infectious agent, above HIV/AIDS. In 2019, an estimated 10 million people fell ill with the tuberculosis worldwide. The breakdown of this 10 million was 5.6 million men, 3.2 million women, and 1.2 million children. And TB is present in all countries and age groups. As far as Pakistan is concerned, according to WHO estimates, the incidence per 100,000 population is 230, whereas the prevalence is around 310 per 100,000 population. The mortality of TB in Pakistan is around 39 per 100,000 population. This indicates around 410,000 incident cases of TB and 69,000 TB deaths in Pakistan occur every year. In this slide, you can see uh, four of the provinces are shown over here, statistics related to Punjab, Sindh, KPK, and Balochistan. Then four other regions of Pakistan, which include Azad Jammu and Kashmir, Gilgit Baltistan, and Islamabad Capital Territory, and then FATA. So you can see in this chart, as far as patients who are undergoing treatment, the total number of people who were notified, who were bacteriologically positive, and clinically diagnosed. Then, as far as the total bacteriology negative patients, this bar chart shows over the years there has been a progressive increase in reporting of all forms of tuberculosis cases, all forms, and new sputum smear positive cases. Every disease has some epidemiological determinants, and so does TB associated pulmonary impairment have. The pathogen, as we already know, is Mycobacterium tuberculosis and is very virulent. Then the spread of disease also depends upon host factors, in which immune response, including adaptive and innate immunity, is important, which drive cavitation and fibrosis. Then in the host, genetics modulate the immune response. As regards environmental factors are concerned, which affects the disease progression, include smoking, biofuels, and silica exposure. As regards agent factors are concerned, we've already discussed these, and these include Mycobacterium tuberculosis, which is a facultative intracellular organism ingested by phagocytes and resistant to intracellular killing. The source of infection are both human and bovine. The human case positive for tubercle bacilli and who have neither received any treatment or have not been fully treated are the ones who can spread this disease. And as far as bovine transmission is concerned, it is through infected milk. As regards communicability is concerned, patients are infective as long as they remain untreated. Host factors, the first is age. It affects all age groups. In 0 to 14 age group, the prevalence is around 2%, and in the 15 to 24 age group, it is around 20%. It is more prevalent in males, and malnutrition predisposes to TB. And man has no inherited immunity against TB. As regards social factors are concerned, it is a social disease with medical aspects, also known as the barometer of social welfare. And the social factors include poor quality of life, poor housing, overcrowding, population explosion, lack of education, large families, undernutrition, and lack of awareness of causes of illness. All these factors are interrelated and contribute to the occurrence of spread of TB. Tuberculosis has a huge socio-economic impact on a country. As regards mode of transmission is concerned, it is transmitted mainly by droplet infection and droplet nuclei by sputum positive patients with pulmonary tuberculosis. And coughing generates the largest number of droplets of all sizes. The frequency and vigor of cough and ventilation of the environment influence transmission of infection. As regards the incubation period of TB is concerned, the time from receipt of infection to the development of a positive tuberculin test ranges from 3 to 6 weeks. And the incubation period may be weeks, months, or years in certain cases. The development of disease depends upon the closeness of contact, extent of disease, and sputum positivity of the source. As regards types of TB are concerned, it includes pulmonary and extrapulmonary. In active cases, most commonly involves the lungs in 90% of the cases, and the symptoms include chest pain and prolonged cough producing sputum. However, about 25% of the people are asymptomatic. As regards extrapulmonary tuberculosis is concerned, in 15 to 20% of active cases, the infection spreads outside the lungs, causing other kinds of TB. And this is more commonly seen in immunosuppressed persons and young children. As regard extrapulmonary tuberculosis is concerned, the most common sites are genitourinary tract, intestines, bones and joints, lymph nodes, and the meninges. A potentially more serious widespread form of tuberculosis is disseminated TB, which is commonly known as miliary tuberculosis, which constitutes 10% of the extrapulmonary cases. As regards pathogenesis of tuberculosis is concerned, once a person gets infected with Mycobacterium bacillus, there is an immune response, and the epithelioid macrophages try to engulf the bacteria. There are multinucleated giant cells, there are lymphocytes, and in the Gohan complex, a Gohan complex is formed which has a central caseous necrosis. And this Gohan complex then progresses further. This is developed in the first 2 to 3 weeks of infection, and then in the next 4 to 5 weeks, there is tuberculin reactive hematogenous dissemination, which continues during the 6 to 8 weeks. And then on 1 year, there is a Simon locus, and bacilli not contained in macrophages can reactivate the disease even later in life. This also shows the pathogenesis, cycle of pathogenesis. There is an initial infection, then there is an innate immune phase when macrophages become active. Then there are neutrophils, there are necrotic cells, and it further moves on because of the adaptive immune phase. There could be different outcomes. One could be eradication. There is a calcified granuloma. There could be the play of T cell immunity and immune factors, in which Mycobacterium tuberculosis is controlled. And then there is a case when there is cavitation and formation of fibrosis starts going ahead. And this is the condition uh, when a person is infected, and a percentage of all these individuals then spread the disease to other individuals. We've already discussed about communicability, how it happens. As regards the signs or symptoms are concerned, there is progressive fatigue, malaise, anorexia, weight loss, chronic cough which is productive. There could be pleuritic chest pain. Then there are night sweats. In certain cases, there is, as the disease progresses, there is hemoptysis in the advanced state. There is low grade temperature in the late afternoon. As regards treatment is concerned, TB medications for 6 to 12 months need to be given. The activity of the patient should be reduced and keep him or her isolated until negative sputum um, um, is seen. As regards the diagnosis is concerned, TB skin test screening is done, chest x ray is done, and then we do sputum studies, and three specimens of sputum are collected on different days. As regards the symptoms are concerned, according to the uh, disease condition, in established pulmonary tuberculosis, in primary pulmonary tuberculosis, in established pulmonary tuberculosis, there is productive cough. In primary pulmonary tuberculosis, there are structural abnormalities. In tuberculosis pleuritis, there is chest pain. Then, in certain cases, there is return of dormant tuberculosis, in which we see cough with increasing mucus, coughing up blood, and extrapulmonary tuberculosis. Common sites are meninges, lymph nodes, bones and joints, genitourinary tract, intestines. So, some common signs or symptoms include night sweats, weakness, fever, dry cough, weight loss, and gastrointestinal symptoms. These are again summarized over here. The signs and symptoms of active tuberculosis. These clinical features include loss of appetite, chills, night sweats, fever, fatigue, unexplained weight loss, chest pain or pain with breathing or coughing, coughing that lasts 2 or more weeks, and coughing up blood. WHO estimated in 2017 that 1 million children become ill with TB each year, and this represents about 10% of all TB cases. Around 233,000 children die from the preventable and curable disease of tuberculosis, and the estimated deaths only include HIV negative children. Actual burden of disease in children is likely higher, especially given the challenge in diagnosing childhood TB. This is the same thing we've already discussed. There is not much difference as far as the agent is concerned, source of infection, and communicability is concerned. However, children with TB are most likely to be found in poor families when there is lack of knowledge about the disease and live in communities with limited access to health services. One of the major causes of progression of disease um, to complicated forms is because of delay in TB diagnosis, or if the treatment is started late. As regards the patient is concerned, the individual factors related to him or her include lack of knowledge, interpretation of symptoms as less severe, stigma, poor health seeking practices. As regards social cultural factors are concerned, it includes a male dominance, masculinity, gender roles, and cultural beliefs. And then we have the structural factors, which include distant health facilities, lack of finances, poor diagnostic infrastructure. And the consequences of delayed diagnosis is prolonged period of suffering, delayed diagnosis, increased transmission, high disease burden. All those who get HIV due to reduced immunity, they are most likely to get tuberculosis. And people living with HIV 26 to 31 times are more likely to develop TB than persons without HIV. Most common presenting illness is among people living with HIV, among those taking antiretroviral treatment. It is the major cause of HIV related death. And in sub Saharan Africa, uh, in the last decade, it was seen that there was a dual epidemic of HIV and TB, accounting for approximately 78% of the estimated burden of disease. Collaborative activities are required to address the TB HIV complex, and WHO recommends a 12-point package of collaborative TB HIV activities, the objectives of which are to reduce burden of TB among people living with HIV and reducing burden of HIV among TB patients. And the implementation of these activities took place between 2005 to 2011, which helped save 1.3 million lives. Then, universal access to these life saving measures must be achieved to eliminate HIV associated TB deaths. Multi drug resistant tuberculosis is defined as tuberculosis that is resistant to at least isoniazid and rifampicin, the two most powerful first line treatment anti TB drugs. When the course of antibiotics is interrupted, levels of drug in the body are insufficient to kill 100% bacteria and spread from person to person as readily as drug sensitive TB and in the same manner. Most commonly, this develops in the course of TB treatment, and that is because of inappropriate treatment, missing doses, failing to complete their treatment, and multi drug resistant strain can transmit TB if pathogens are alive and patient is coughing. TB strains often less fit and less transmissible, and outbreaks occur more readily in people with weakened immune systems, and that means those who have HIV. The prevention of drug resistance TB is through rapid diagnosis and treatment of TB on time. One of the greatest risk factors, especially in developing countries, is delayed diagnosis and delayed start of treatment. If TB is identified and treated soon, drug resistance can be avoided. Then, completion of the treatment is very important. Previous treatment of TB is an indicator of multi drug resistant TB. Incomplete antibiotic treatment or improper prescription of antibiotics can lead to development of resistance. Drugs that are of poor quality or underdose, especially in developing countries, contribute to multi drug resistant tuberculosis. As far as prevention of drug resistance is concerned, patients with HIV/AIDS should be identified and diagnosed as soon as possible. They lack the immunity to fight the TB infection and are at great risk of developing drug resistance. Identify contacts who could have contracted TB, that is, family members, people in close contact, etc. Much research and funding is needed in the diagnosis, prevention, and treatment of TB and multi drug resistant TB. Then we have the extensively drug resistant TB, which is defined as TB that has developed resistance to at least rifampicin and isoniazid, as well as to any other of the quinolone family antibiotics and at least one of the following second line anti TB injectable drugs. So, uh, there are three types. One is normal TB, then we have the multi drug resistant TB, and then we have the extensively drug resistant TB. If TB bacteria are found in the sputum, diagnosis of TB can be made in a day or two, but can't distinguish whether it is drug susceptible or and drug resistant TB. We cannot distinguish. To evaluate drug susceptibility, bacteria need to be cultivated and tested in a suitable laboratory, and the final diagnosis in this way for TB and especially for extensively drug resistant TB may take from 6 to 16 weeks. The original method used to test MDR-TB or XDR-TB, which are the terms used for multi-drug resistant TB and extensively drug resistant TB, the drug susceptibility testing is done. The drug susceptibility testing is capable of determining how well four primary anti-tuberculosis treatment drugs inhibit the growth of Mycobacterium tuberculosis. As regards the prevention and control of tuberculosis is concerned, primary prevention is of prime importance, which includes health education and specific protection. Population strategy and high risk strategy is required to be employed. Then, secondary prevention includes early diagnosis and specific prompt treatment, and tertiary prevention includes rehabilitation and disability limitation in cases of patients where there has been fibrosis of lungs or other extrapulmonary causes have progressed more than expected. Then, early diagnosis and treatment, particularly of sputum smear positive cases, and this is the cornerstone of tuberculosis control. Then, the revised National TB Control Program has focused on achieving high cure rates, and the positive efficacy of BCG has ranged between 0 to 80% in different studies. The first human was vaccinated by the intradermal technique in 1927, and the BCG is the only widely used live bacterial vaccine. It consists of living bacteria derived from an attenuated bovine strain of tubercle bacilli. The World Health Organization has recommended Danish 1331 strain for the production of BCG vaccines in those countries who are producing BCG vaccine. There are two types of BCG vaccine, the liquid fresh vaccine and the freeze dried vaccine. For vaccination, all remember the usual strength is zero point 0.1 milligram per zero point 0.1 ml volume, and the dose to newborn aged below 4 weeks is 0.05 ml. The National TB Control Program has devised strategies from time to time and have improved in controlling TB and treating patients. Pakistan has had an ongoing national TB program, and reviews show that only 30% of the estimated tuberculosis patients were diagnosed and treated successfully. The WHO Directly Observed Treatment short course strategy for TB was adopted and piloted in Pakistan from 1995 onwards. But major progress in TB control was only achieved after the revival of the National TB Control Program in 2001 when TB had been declared a national public health emergency. As regards the components of the National TB Program are concerned, these are the directly observed treatment, short course directly observed treatment strategy, along with the other ingredients of the Stop TB partnership, are implemented as a comprehensive package for TB control. The five principal components of directly observed treatment strategy dot include political and administrative commitment, without which nothing can happen. Case detection by sputum smear microscopy, uninterrupted supply of high quality anti TB drugs, standardized treatment regimes with directly observed treatment for at least the first 2 months, and finally, systematic monitoring and accountability will help improve the outcomes when treated with the DOTS under the DOTS program. As regards diagnosis is concerned, the MANTOUX test is a screening test, or we see tuberculin sensitivity test. Tuberculin is a glycerol extract of the tubercle bacillus PPD tuberculin precipitate of species non-specific molecules obtained from filtrates of sterilized concentrated cultures. A standard dose is 5 tuberculin units. 0.1 ml is injected intradermally between the layers of dermis and read 48 to 72 hours later. The reaction is read by measuring the diameter of the induration, palpable raised hardened area across the forearm perpendicular to the long axis in millimeters. As regards the classification of tuberculin reaction is concerned, the person's medical risk factors determine at which increment 5 mm, 10 mm, or 15 mm of induration the result is considered positive. A positive result indicates TB exposure. If 5 mm or more is positive in an HIV positive person, persons with recent contacts with a TB patient, persons with modular or fibrotic changes on chest x-ray consistent with the old healed TB, patients with organ transplants, and other immunosuppressed patients. In case 10 mm or more is positive, this takes place in injection drug users, residents, and employees of high risk congregate settings, example prisons, nursing homes, hospitals, homeless shelters. Then, mycobacteriology lab personnel may show this kind of positivity. Then, persons with clinical conditions that place them at high risk, example diabetes, prolonged corticosteroid therapy, chronic malabsorption syndromes, etc. And then children less than 4 years of age or children and adolescents exposed to adults in high risk categories. When 15 mm or more is positive, this happens in persons with no known risk factors for TB. The Stop TB strategy has six major components, which include DOTS expansion and enhancement, addressing TB, HIV, MDR, TB, XDR TB, and other challenges, contributing to health system strengthening, engaging all care providers, including physicians in the private sector, empowering patients and communities, enabling and promoting research involving not for profit organizations. So, at the end, while summarizing, I would say in this first lecture that despite all these national programs and efforts from Government of Pakistan, TB still continues to be a major cause of socio-economic burden and ill health for the country. And there is need to create awareness among healthcare professionals and the community. Thank you, ladies and gentlemen. I'll just share with you a TB notification which is a step forward in the identification of patients. And this has mainly been done with private clinics and hospitals. The takeaway message for today, and normally we messages are also given on the World TB Day, which is celebrated on March 24. The takeaway message for you is that it's time to test and treat latent TB infection. It's time to speak up. It's time to end stigma. It's time to strengthen TB education and awareness among healthcare providers. It's time to end TB. With this, I end today's session. You are most welcome to ask any questions. In the second lecture, which I will deliver soon, we will discuss some other aspects of tuberculosis. And similarly, I'll conclude the topic of tuberculosis in 3 sessions, inshallah. With this, I thank you all and pray that all of us remain healthy and our loved ones remain healthy, the communities in which we live are healthy. But for that, you need to know that prevention is better than cure, and we have to focus on preventive health. Thank you very much. Allah Hafiz and take care.